Good afternoon, everyone. Thank you very much for coming. This is an expert discussion on a really exciting topic. This is being recorded and going live on the internet at the moment, so we have people viewing. So hello to viewers at home and at work. We're really keen that this is an interactive discussion, that there's lots of expert opinions in the room as well as our colleagues on the stage, and they're really keen that we all take part in that. So we have some questions that we received in advance of today. I'm sure you all have many more questions, and our colleagues on the panel might have questions as well for all of us, so we'll see how we go with that. To start with, a couple of introductions. My name's Jo Hart. I'm the new chair of the DHP.
Button. Failed at the very beginning of the lesson that I was just given. Sorry. Okay, I'm still Jane Ogden, and I'm still a professor in health psychology at the University of Surrey.
I'm Paul Flowers. I'm Professor of Public Health Psychology at Glasgow Caledonia University.
I'm Anne Kazack. I'm Director of Research Center for Healthcare Delivery Science out of Nemours Children's Health Network, and I'm based in Wilmington, Delaware.
Thank you very much. We're absolutely delighted that our keynotes have all agreed to join us today for this. This has been organised by the Publicity and Liaison section of the Division of Health Psychology Committee, thinking about how we communicate about what we're doing and how we can use the conference to really discuss and debate these issues, and how that can also be a benefit to members who aren't able to be here in person but are able to listen to our discussions, and hopefully have been able to submit questions in advance if they had burning questions to ask. So, we've got a few kind of questions that I'm going to kick off with, and we'll have a bit of discussion about that. If you have questions, I would ask that you introduce yourselves before you ask your question, just so that our viewers at home know who it is asking questions. So, the topic of our discussion today: will systemisation bury or elevate health psychology? And this is part of the thinking about the current move within the discipline towards the adoption of systematic approaches for design and evaluation of behaviour change interventions. And I think people in the room and people who are DHP members more generally have a mix of views on that, and we thought it'd be a really good thing to talk about. So let's start with one of the questions that we received. So, do the panel think it would be possible to ever reach a consensus over theory and models of behaviour change?
Is it like a buzzer system? I don't think it would be possible to ever get there, and nor do I think it would be desirable to get there. I suppose what I've always liked about health psychology is that we are a broad church. We have people from all sorts of different backgrounds. We have social psychologists, we have developmental psychologists, we have biological psychologists, we have people who are clinicians, people who are doing research, people who are a mixture. And I think that's what makes it exciting, and it makes it inclusive. And I think I like that breadthness, and I think that breadth gives you a sense of change, and also it encourages creativity.
I would agree with Jane. You know you're going to have to go next time. So I think the answer is no. I'd say different kind of reasons, that the world changes, our society changes, the health behaviours change. As we have interventions which work, we need to be able to respond to new challenges, and so we do need to constantly innovate in theory and method as we address different kinds of challenges and come up with different solutions to challenges. So if we take the kind of low-hanging fruit first, and we have effective interventions for behaviour change there, then we do need to move on, rethink new challenges, probably new methods and potentially new theories to address those challenges.
I have to admit that I'm not quite sure what it is that we're debating. And this is, encouraging audience participation, help me understand what it is that we're talking about. So this is kind of interesting because I think some of the language and perhaps some of the ideas are different in different countries. I'm not really aware of, that doesn't mean they don't exist, but I'm not necessarily aware of exactly these words being used to describe it. So, I mean, I think that health psychology is a very broad umbrella in the States, and from what I know around the world, and does in fact include many different types of people practicing with many different patient groups, and it is constantly evolving. I mean, our healthcare system is trying to change. It is changing. It's broken. And so I think there's lots of opportunities for health psychologists to be involved in changing practice and also changing the systems.
Thank you. I think that's really interesting. People might want to pick up on that about the international language and how what we're thinking about in the UK, how that's understood internationally, and if it's maybe not, what that means for what we're thinking about in the UK and our work being internationally focused. Yeah. Okay, so one of the questions we received by email was about when we're thinking about a single theory or a framework or the systemisation, why is that focus on behaviour change rather than a broader psychological interventions? Is that anything any of you would like to respond to?
I think very briefly, that's just where our discipline happens to be focusing at the moment. So over the years I've been coming to this conference, we've had lots of different things which have come in and out. For a while we were very social cognition orientated. For a while we were extremely self-regulatory model focused and looking at illness cognitions and sense making. For a while we were very dominated by IPA and lots of people doing qualitative research, and then we've moved on at the moment to looking at behaviour change. So that's just where we are at the moment when this has happened, and we won't stay there, we'll move on to something else, and we should welcome that. Whatever that next thing is, we welcome that, and we gather all those things as we go along, so we're all these things together.
It does feel like positive.
Next time you can go first and I'll agree with you.
Oh, I was going to disagree with you, I think. I don't know, it was a kind of aside really. It was about, I think it's important to remember the kind of macroeconomic context in which we're working and in which the discipline is growing and flourishing. So I think some of the question taps to a difference in terms of we're all held accountable in terms of the spend of public money. What difference are we making? So I think there is a kind of era where we're refocusing on behaviour because we need to be able to show what we can achieve. We need to be able to celebrate our success. We need to be able to celebrate the cost effectiveness of what we're doing. A lot of that is a lot easier with behavioural outcomes versus, for example, softer psychosocial outcomes such as identity perhaps or affect. So I think it's important to take that issue and that particular contemporary focus on behaviour and behaviour change within much more kind of macroeconomic drivers of what's happening in the systems in which we work, what's happening in the NHS, what's happening in terms of the university sector in the UK as well, for example.
Is that anything any of our audience members would like to add to or comment on or question that area more? Angel? Those of you who can't see that, some of our roving mic members weren't ready for that moment.
Hello,
they will remain nameless.
Okay, hi. So it is on. I'm Vivian Swanston. I work for NHS Education for Scotland, and I'm quite engaged in practitioner health psychology, so thinking about how psychology can work in practice. I think we've kind of lit onto behaviour change as something that health psychologists can almost uniquely do as a practitioner role. And I think that's probably slightly dangerous, because I think if we only focus on being able to change behaviour as professional practitioners, it makes us look a little bit limited, because we're not actually the only profession that can change behaviour, although we kind of pretend sometimes that we are. So I actually think the focus on behaviour, I can see why it's there, because it's very kind of politically and culturally current, this focus on people's health behaviours and trying to change those. And I think we've leapt onto that as practitioners to say, oh, we can do that, and therefore we're useful in a practitioner sense. But I think it's perhaps a bit of putting our eggs in one basket, so I don't think it's a good idea.
Thank you. Any other thoughts on that?
Actually, can I ask, sorry, I might have been... Di, that'd be really irritating. But we had a little conversation last night, didn't we, about cancer research. and how the shift has gone towards prevention and behaviour change as opposed to the rest.
Thank you, Jane. Yeah, I'm Di Harcourt from the Centre for Appearance Research at UWE in Bristol. That conversation we were having, it ties in with this, the fact that, for example, funders, we were talking about Cancer Research UK and how their funding is very much on behaviour research and population research, and we were talking about the fact that a lot of health psychologists, we may be doing things, for example, survivorship and people living with chronic diseases, and that may not come under the behaviour change heading. So I think if you focus on behaviour change, you're actually restricting what we do, and we're much broader than that.
Okay. Anything else on that? So the eggs in one basket concern, we'll call it. Yes.
I mean, isn't it also possible that it's to do with who's making the agenda about what funders will fund? So if you have powerful groups doing behavior change and they're setting the research agenda, then wouldn't that then by necessity sort of attract attention to those, to focusing on behavior change, and then eventually other areas will follow suit as, they become more developed or more powerful in the research agenda or clinical agendas or so on. I mean, there's a political face to this, is what I'm trying to say.
Mm-hmm. Who should be making the agenda, do you think?
Well, that's a really interesting question, because you could come up with all the ideals, the perfect, who should be making this, but these decisions, but in the end, as Paul said, it's the economics of it, the clinical commissioning groups, and they work with particular hard outcomes. So, the who should and who does are two different things, I think.
Can I come in? I do think it's really important to think critically and think about the context of the economic drivers behind our focus, but I also think it's really important to just, to be motivated by the kind of public health imperative of epidemiology, of disease, of the ageing demographics. So I think, absolutely behaviour change should be core to what we do, but it doesn't preclude a focus on understanding wider cultural change in terms of understanding sort of systems level thinking. So there's, those behaviours are embedded in particular contexts. I think it's very positive that we're maturing as a discipline in terms of our focus on behaviour change. But I do think it's important to bear in mind that there is also an imperative to think much more wider at different levels about how we can change the drivers of those behaviour, for example.
Sure that the funders are on board with that and that they fund that kind of research as opposed to some other kind of research, because otherwise you're not going to so if you want to develop the research stream on drivers, then that's the funders have to fund that research. Do you see what I mean? So,
but I feel optimistic about the funding environment in terms of its kind of openness to interdisciplinary perspectives. So there is absolutely a role for us to be contributing. So I don't think necessarily the funders are particularly putting, constraining what we do.
Well, I don't think it's the funders. I think it's the panel members on those funding bodies. So they're the ones that set the agenda, really, not, the experts, in other words. We need to be broader in our thinking is what I want to communicate.
So we need to be broader in our thinking and maybe have more health psychologists on those panels as well to be helping to set that agenda.
Health psychologists in different areas.
Yeah.
Yes, the heterogeneity of health psychologists on different panels, but it's also important to think about the heterogeneity of our funders. So the difference between thinking about funding from MRC versus ESRC versus NIHR, each of those funding bodies, and all of the kind of charity and kind of third sector funding opportunities, each of them has a kind of different flavour. It isn't that all of them are completely focused upon you can only be a health psychologist if you use the behaviour change wheel, for example.
Okay, moving slightly onto a different topic within the systemisation debate. Is there a risk of a move towards systemisation that health psychologists in both practice and research are talking themselves into extinction? There'll no longer be a need for health psychologists with that expertise, as other health professionals will just be able to look things up. Is that a risk?
Well, I mean, I think that's where my biggest fear came from this in some ways. And I think, I mean, there's a sociological literature about the way in which people work and the ways in which jobs turn from being professional jobs into becoming technical jobs or technician jobs. And I think the more things are kind of rule book or protocol driven, then the easier it is for absolutely anyone to pick up that protocol and just do it. And the job of being a professional, whether it's a professional health psychologist in a practitioner way or an academic way, is having a whole load of other skills which are outside of that protocol, really. And so what's happened, I think, is that the systemisation has been brilliant for other people, whether it's physios or osteopaths or pharmacists or GPs. They can pick up this thing and go, look, I can now develop an intervention or deliver one. But actually what we have is a whole load of other skills, and we should be able to use those as well. And I think the more structured it becomes, and less we lose what we've got, which is special. And that seems like a shame.
I think I really welcome systemisation, and I welcome the kind of democratisation of our theory and our methods. I think what systemisation has done is it's a kind of marketing tool for public engagement, for community engagement, the public understanding of our science as health psychologists. So I think there's many, many positives. I do agree with Jane in terms of what we have as health psychologists is a particular skill set to be able to think about the individual as a kind of unit of analysis, a unit of kind of thinking about interventions that can be quite unique in terms of that's the way we're drawn to thinking about complex systems of healthcare, health delivery, or behaviour change. And I think that's something, so I work a lot with interdisciplinary teams, and although there's something very, very generous about the way people can understand what we do, in a way I would say they couldn't understand what we do 10 years ago, I certainly don't feel sort of threatened or that other disciplines will colonise what we do. I think it's enabling a dialogue and a communication with multidisciplinary and interprofessional teams, which is exactly what the world needs in terms of being able to address the complex problems which we have to.
Rachel.
Hi, I'm Rachel Shaw. Is this on? Yes, it's on. From Aston University. I think on that point about the other skills that we have as health psychologists and the difficulty of systematising them, can I turn that into a verb, is we need to be aware of these kinds of the tacit skills that we have, the kind of knowledge that we're using. And I don't think systematising those things downplays them or dilutes them in any way. It's having them in the manual, but to be able to perform what's in that manual, you have to be a health psychologist. So you can have that kind of, I don't know what to call it other than the kind of professional judgment type skills can be in the manual. If we're going to be thinking about systematising skills in that way. It's something that we need to get better at, I think. I think as psychologists we have this huge kind of imposter syndrome where we just think we can't do these things. So we'll just train other people and they can do them and we'll tell them what they need to do. I think we need to be much more self-aware in the skills that we're using. And I think we don't emphasise enough the different types of skills that we have. Our competencies clearly state these different areas of our practice. And I think we undersell them. So I think we should perhaps be a bit more proud of what we're able to do. I feel a bit like I've waffled on a bit now, so I'll hand the microphone back. Thank you.
Any other
So
thoughts?
is this partly a matter of public relations and how we sell ourselves, and do you have that elevator talk ready when you get in an elevator and there's a physician or a nurse from an area who really doesn't understand what what you do?
Because I think that is the whole issue, isn't it, about the continuum between things being really, really complex and things being really, really simple. So what we've been doing for years is having lots of words and lots of language and lots of models and lots of theories, and then we say to a public health person, and they go, oh, well, that's no good, and that's no, we go, read this paper, and read all of this, and that'd be really useful, and they look at us and they think, oh, that's the end of that. So that doesn't work. But then what we do is we create an elevator pitch, which is really simple, and they love it because it's really straightforward, but actually it's not honest or true, or it's kind of misrepresenting what we do. So they love it because they get their elevator pitch, but actually we've oversimplified what is actually quite complex. So the trick is to get the clever stuff and the complexity, make it understandable to other people, but not sort of lose our integrity by pretending that we know stuff that we don't, or we've got answers that we haven't, or models that work when they don't. And that's the danger, is by getting that elevator pitch, we sort of, it's a bit fake.
Can I come in?
Mm-hmm.
So, I disagree with you. I don't think there's anything dishonest about what the frameworks can give us, which is clarity of direction and purpose. So, although they are equally good rhetorical, communicative devices to get people to engage with what we do, because of that intuitive logic, I don't think that when we use the systemised theories that it's prescriptive kind of microscience. To me, it does require our imagination, our creativity, our agility. It's the honesty of the direction is, here's the problem. It's complex and obdurate kind of barriers to behaviour change. What we can do is work systematically at trying to reduce those barriers and change people's behaviour. And it is absolute honesty of kind of direction, which I would say, if we think about previous kind of eras and incarnations of health psychology, I don't think we've really had that. So to me, the elevator pitch, it's not dishonest, it's absolutely where we're at and where we should be growing. And the kind of anxiety about systemisation, that it sort of precludes innovation or exploration, I think, to me, that kind of troubles me. If we have an idea, we can use these models in a very prescriptive way. They're there as tools. Our roles and responsibility are to use them well, tailor them to specific contexts and situations, and that requires just as much sort of methodological pluralism and theoretical innovation in a different way than we had in the past. And I don't know if I'm making sense, but there's a clarity to me which is absolutely honest, and it absolutely kind of tailors what we do with what I think the discipline should be doing, which is making a difference to people's lives and health.
But
Sorry, go on, Jane.
But I suppose we did lots and lots of stuff as a discipline, and we published all over the place, and we had lots and lots of research, and then we stopped, and then we pulled that together and said, right, here's a systematic approach of all this stuff that we've done. Well, what in doing all that stuff we hadn't finished? Or what if there was other ideas that weren't in that pool that have now been pulled together? Or what if there were things that were unsaid? If we hadn't finished, which I don't think we hadn't identified everything and thought about everything, and we never could do, then when you apply this final version, which is only as big as that pool at the beginning can be, it's going to miss stuff. So I suppose, what I do lots and lots of studies with my students, and we do, lots of, I think, quite interesting, inductive little qualitative studies. The loveliness of all of that is that new stuff comes out all the time still. I speak to, people with leg ulcers. Well, I don't, Pippa does. And she finds things. Or Sam talks to people with cancer and they find things. And that wasn't in this beginning bit. It's still all new. So we sort of stopped too early. And then we did this pooling up. Maybe in 100 years' time or 200 years' time, we've generated all the ideas. Then we can stop. But we weren't ready to stop.
Not for a second do I think we should stop, and I think we absolutely do need to continue and grow in terms of how we think about exploratory, observational health psychology. how we look at new issues, how they emerge, how we use particular qualitative approaches to their best ability, how we use the kind of full spectrum of different methodological approaches. All of that is absolutely core business to how we should be thinking about being health psychologists. I also think strongly, believe strongly, that that's core business to how we should do behaviour change interventions, and it's the work, the kind of pre-intervention work that we should be doing before we move down into issues such as operationalising the behaviour change wheel. So to me, they're not mutually exclusive at all. It's how we have that portfolio of different methods, different tools, how we think and how we mature as a discipline into understanding what we do in different sort of stages of the exploratory observational work, how we move on to thinking about intervention development, intervention implementation, and cycle way back. So it's an iterative and ongoing process, but it would be awful if it was an end to new stuff and very inductive, open-ended theorising and methodological development and everything.
Thank you, Paul. We've got a question there in blue. Thanks.
I wasn't going to give a question. I'm at City. What I was going to say was I work primarily with people who are really vulnerable, have really limited access to healthcare, because they have learning disabilities and they're getting absolutely hammered in what they provide. But I've been able to use some things from the systematic, theories and models that are out there to try and leave them with something that they can use going forward, because the funding isn't there for specialist support. The people that support them, they don't have a lot of availability for training and specialist, input. So I have to use what's out there a little bit and my knowledge of this population to try and work with them on something that will last. So from that point of view, the whole point of it being democratic is really useful. Doesn't mean I'm not going to then look at and say, okay, yes, this is useful, but we need support, ongoing support for them to actually be able to use this effectively, or that new things don't come up, because they will come up. But so I can use more inductive things whilst I'm still looking at the top-down things. I don't think, like you say, that they are exclusive.
Okay, thank you. And we have another point, 2 rows forward, and then quite a lot of points over that side of the room.
She was first.
Okay, yeah. Thank you.
Hi, Sophia Stromer. I'm from the MRC LEU in Southampton. And I was just thinking about how this isn't a very unique thing to health psychology. Of course, there are other, it's not a discipline, but for example, you have cookbooks, right, as an example of systematization. And if you have a specialist diet, this might be useful to you, and you can learn the basics of cooking, you can learn how to do gluten-free stuff, but it doesn't make you Heston Blumenthal. So there's elements that we can do that are beyond the instructions that we can give other people that will be helpful. So I don't think it's a threat, necessarily.
Thank you. And a question behind.
Thanks. Hi, Kirby Sainsbury from Newcastle University. I think there's a distinction that needs to be made between the development and evaluation of interventions and the reporting of our interventions. And I see the systematisation as being very helpful for the reporting of interventions, because it gives us a language with which to communicate to other people in a way that we haven't necessarily had before, because everybody was using different labels for different things, and you might have been doing the same thing but didn't know you were doing the same thing because somebody else used different words to describe it. Whereas when it comes to the development of interventions, we've all been, and I say this as a relatively young health psychology member, we've all been doing intervention design and delivery and that kind of thing for a long time before the systematic approach came about. And I don't think it changes the way in which we do it. It's more an overarching framework within which to still have that flexibility. And I sort of liken it to the DSM, for example. Within the diagnosis of depression, you can have something like 100 different presentations, all of which have different combinations of symptoms, but all meet the diagnostic criteria of depression. And saying to another health professional, this person has depression, tells you something about that individual in one word that you wouldn't necessarily get across in a much more detailed conversation. So it's not the end point, but it is a useful way of kind of starting that conversation. So by being able to say, I used this theory, I looked at this construct, I used this BCT, it communicates something much more simply. And we know as health professionals that, and academics and whatever your background is, that the complexity that's gone into that is huge, but to the outside world and as a bit of a shortcut, we have a language now that we didn't before.
Okay, so you feel it's helpful. Yeah. Any other thoughts on that particular point from Kirby? Richard?
It is on, right. Yes, I would just agree with Kirby.
Do you want to introduce yourself? Sorry.
Sorry, I'm Richard Cook from Aston University. As somebody who does a lot of systematic reviewing and meta-analysis, anything we can do to improve the consistency of reporting of results is to be welcome from my point of view, because they can be a bit of a nightmare to put together in terms of reviews. If people, so we have things like consort and other standards for reporting. So, but I do take the point that when you're thinking about developing interventions, you need to often have quite an open mind about what you can do. I had a stage 2 trainee, and she was looking to develop an intervention for people with problematic asthma, and we sort of followed the kind of training that she'd gone through on her PhD, and ultimately we had to kind of make a series of judgment calls, which you still have to do, I think, even with frameworks and all these things. And what we came up with was awesome and worked really well, which is great. But I think you'll always end up having to have that professional judgment on top of the knowledge that's there.
Okay. Any other comments on that? Anything from our panel on that? No? Okay. Other questions? I think there was other questions over this side of the room. Or comments, thoughts? Yes? Mag's over there, third row.
Sorry, I'm Kirsten Hunter, and I'm a stage 2 trainee in NHS Grampian. And I think what I find interesting just about these kind of things is that we're saying we're systemizing things and we have models and that anyone can pick them off the shelf, yet I'm coming up to a year into my stage 2 training, and I find it really difficult to do, and it's still really hard. So if we as health psychologists have to do 2 years to minimum to evidence that we can use these models and these systemized things in a way that's useful in applied settings or in research, I think we're selling ourselves short to say that we're going to, I suppose, bury the profession if we systemize it and give it to other professions when we ourselves take time to develop to be able to use what's already systemized.
Okay, thank you. Want to respond to that? Thank you. Any other points about that, the training and the development of expertise in this? Yes.
Hi, Vicky Staples from the University of Derby. I think we can draw together a number of those points in the idea that if we've generated little cookbooks, we all know the little red cookbook that's currently available, and to see other disciplines now developing and applying and doing the work in that, I think it's going to make our evidence base very, very messy, because working with people outside of the discipline who have picked up the little red cookbook and are doing doctoral level work, they think they're doing doctoral level work using things like the behaviour change wheel, but they don't really understand the weight of the theoretical background, how it relates to previous theory research. They don't have the same research methods training to really be able to evaluate well what they're doing. So what we're going to get potentially with there being behaviour change courses for non-psychologists who are out getting people to recycle their rubbish more in local authorities, I think we're going to get a very, very messy literature that is going to make it more and more difficult to establish exactly what that evidence base is. So whether we will be inspired or perspire, I actually think that there's going to be issues down the line in terms of us having the debate, and we do this to ourselves. We debate whether we're doing the right thing in the right way, and other people will run with it and will do it more cheaply, with less rigour, And I actually think it might have implications for us as a discipline in unintended consequences. So I think it's helpful. I think having shared language is helpful. But seeing the abuse of what we are putting out there by people who are wielding it in ways that they shouldn't be allowed to have the box of matches, I think there are some dangerous days ahead.
Any thoughts on that?
I kind of don't share those concerns. I think there's something around the kind of open source mentality of systemisation which is really positive. As I said, it's to do with how we engage our colleagues in other disciplines, professions. It's all part of it. So I do hear what you're saying about potentially people can use it poorly, but if we have a maturer and more clear evidence base, people will be able to not be designing their own interventions, but implementing their own interventions. So it's not that we expect other people to be doing the groundwork of all the multi-method, all the theoretical honing in terms of then systemising the theoretical approaches to make the best interventions. Probably that's what we can do. But surely one of the kind of the issues is we want to be in a position where we can make reasonable, or not we, but people we work with, commissioners of services, commissioners of practice, can make reasonable off-the-shelf intervention packages, which we have been involved in, but they're implementing them.
I think that's brilliant, and I would love to think that if we preface that with that we have been involved in, and my concerns are that actually health psychologists are expensive, psychologists are expensive, and other people will put themselves forward, and it will be a case that we're not involved in at all levels. I think opening up and being able to work collaboratively and being able to speak to other disciplines, when those disciplines share the same sort of rigour of their own discipline and science, makes for really fruitful work. But just odd observation so far. Just an observation.
I suppose, can I just add into that I think that is one of the sort of tensions between tailoring our interventions and having off-the-shelf interventions, isn't it? And, out there's a whole body of people running workshops on how to develop tailored interventions to the needs of a specific patient group. And then there's a whole other body of people running workshops on how to run off-the-shelf interventions, which will work for most of the people most of the time. And those are two very different worlds. And if this world wins, then that's what we're going to be offering, is off-the-shelf, off-the-peg interventions for people which forget about that whole world of literature, which is saying how important it is to find out the individual needs at the individual time, where they are in their individual life, and then specifically tailor them. And that's time-consuming and costly, and that's cheap. So people are going to do the cheap off-the-shelf one as opposed to the effortful tailored one.
If the cheap off-the-shelf one is better than what would have been offered otherwise, I feel comfortable with that. It's not ideal, but it's better than an intervention being commissioned willy-nilly or other way. I think I know someone wants to speak, but there's something about the maturity or the celebration of where we are as a discipline that I think we can afford to be more confident about the added value we bring as health psychologists. So it's just to kind of disagree with you, Vicky, just about your very gloomy version. I think, no, we can afford to be generous, and we can, as there's an onus on us as health psychologists to deliver on that promise, to deliver on that honesty, but that does seem feasible and realistic to me.
But in the language of evidence-based practice, we've got to offer an off-the-shelf thing which works, and we can't pretend it does work when there's no evidence that it does work for that particular patient group. And that's the problem, isn't it? It's steering away from the evidence base all the time. We are supposed to be evidence-based practitioners, and we don't have evidence that this thing works for everybody all of the time at all. But we're kind of pretending that it does, and that's wrong.
It strikes me that the horse is already out of the barn on this, and I'm probably more on the pessimistic side in some ways, but I'm not sure that I think the problem is economic, and the discussion of interventions and off the shelf or I'm not sure how important that is. In the States, the American Psychological Association is dealing with groups that are calling themselves counselors of various types, and they're being very effective in working around the types of competencies that we lay out as psychologists. In pediatrics, and I want to just kind of throw this out there, what do the patients want? I think we have to think about what our consumers want. In pediatrics, families love child life specialists. You can hire several child life specialists for the cost of a psychologist. They do great work. They're wonderful. They're child-focused. We have to deal with that. I think we have to think about how can we integrate that into what we're doing, whether it's, again, my experience is more in pediatrics with child life specialists, with social workers, with all these people that are part of the team. And I think we have to think about ourselves differently in terms of leadership in these teams, leadership in policy, and things like that, and perhaps not worry so much about what they're doing with our stuff.
Is it about this point or? Yeah, great.
So that links to something that I've been wondering about, which is how much all of this development is driven by commercial interests, because it has kind of become a little bit of an industry, which I think in some ways is good, because health psychologists have produced an industry that creates revenue, so I just wonder about that sometimes.
Any thoughts from the audience on that point about the commercialisation, or anything about what patients want? Any perspectives from working with patients or thinking about that? Yeah?
Thank you. Hi, I'm Vari. I'm in between. I'm at King's College London and UCL now. I've been part of a trial that I'm going to be talking about tomorrow morning, and I'm mindful of this conversation about I'm quite new on the block in health psychology as well, but around how much information we're giving to other people. And I've worked on a trial where we're enabling physiotherapists to add acceptance and commitment therapy as part of their expertise. And I'm very interested to listen to this conversation and thinking what I've been part of and what we're doing. And I think from a patient point of view, there is some evidence that we've found in our qualitative research that it's more acceptable for them to see a physiotherapist for their condition, for some people. And I think there's been some evidence of that in previous one as well. So I think from the patient point of view, that's there. And I think from the physiotherapist, which I'll share a bit more tomorrow, there's some interesting work, but I'm also very mindful of, there's a lot of talk about they do CBT or they do this, and the psychologists I've had the pleasure of working with would argue they're doing a tiny bit of it, and the language that is used about what they might be delivering is very different to what the health psychology experts would do. And I think the imposter syndrome comment earlier, I completely get that as well. Maybe a lot of it is how we talk about it and being a bit more out there about claiming, not me personally, but other people with all their expertise, but what we do.
I just feel a little bit troubled by some of this, but there's something about if as a health psychologist I'm working with a nurse or I'm working with a medical clinician, there's something about the kind of magic that can happen. I need to understand what they do in their context. They need to understand what I do in my context. But it's something about that interdisciplinary perspectives. It's absolutely fundamental that we are transparent and open in terms of what we're doing, what we're trying to do, because it's a mutually reciprocal and beneficial kind of relationship we have with people. A lot of the problems we're addressing require that kind of imagination, that kind of interdisciplinary lens. So to me, that is fundamental about why we do need to be open and generous and have systemized tools that make sense to other people. It's in order for us to start that dialogue, to be able to understand how we can work with other people who think very differently at a number of different levels, practically in terms of how we're delivering things in the NHS, but also just in terms of the way we do research. So, I have to have dialogues with mathematical modelers, and, I do kind of struggle with some of that, but there's something, I would hope, that's mutually enriching about how we need to have dialogue with, this is our kind of conceptual framework, this is their practical implementation of something, but it's the magic of what we do together and how someone else's perspective illuminates what we do that gives us the kind of real-world purchase or kind of our ability to leave an impact. It's the magic that happens looking outside of the discipline, which necessarily means we have to be open and generous and transparent.
Can I just add to that? I think there's absolutely nothing wrong with being open and generous and sharing everything that we've got with everybody else. And we have a language, we have some models, we have some theories, we have some data, we have some papers. That's all fine. But when we start to say this will work, that's where I get worried, because all that language and all that research I don't think has got to a point yet where we can say this will work, therefore have it and do it with your patient group. I mean, of course, use our words and our language and our theories and our data, absolutely, and go and do what you can with it. But let's not pretend we've got a product yet that is sorted. I mean, CBT doesn't work for everybody all of the time. Of course it doesn't, but CBT is certainly more tried and tested than any of the new products that we've got. And so if we're just going, we've got this thing, have a go with it, that's all right, or this might help you in designing a few things, or this might be useful, that's also useful. But not to say this is our new product. It's sorted, it's not sorted. The evidence base is not there to say this works for all of the people all of the time. It's just another thing that some people out there can try when they want to.
But I do think it's an ongoing process that, yes, we should be committed to making an evidence base that rather than to try and explain the problems of lack of behaviour change for all of the people all of the time or look across the population, then it does come back to really quite, for me, a pragmatic decision of can we do better than would have been offered before, or if we've got standard care or standard practice and we know what it's done, we can look at the kind of baseline data. Can we? I think our job is to improve upon that. And to improve upon that by following a systematic process, by bringing in the years of our training, I think we can definitely improve on that. We might have patchy levels of evidence. It's not necessarily going to be kind of gold standard, high-level evidence, but we can do something useful. And I feel that is, I suppose, part of the moral burden on us as health psychologists. We can add value, and we shouldn't be shy about that. If we can contribute to an evidence base, we should also be doing that. We also need to be using and critically thinking about the existing evidence base. But I think our goals should be a bit more pragmatic.
And that's fine. It's how we sell it, isn't it? We have a toolkit, and in our toolkit we've got some CBT, we've got some mindfulness, we've got some motivational interviewing, we've got some being nice to people and giving them a sticker chart, and we've got some other stuff that's been developed recently. There's our toolkit. Use it. But we can't say this works because we don't know that yet. It's ongoing. So why should anyone use this rather than all those other things in our toolkit? That's all we're saying. Shut up.
Amanda.
It's about...
Would you mind introducing yourself?
Oh, sorry, I'm Amanda with the Behavioural Insights team at Public Health England. I wonder if it's about systematising certain elements of processes. So what we're talking about there is around what the toolkits are, what we can offer, what our skill sets are, where we can add value. And just giving them out there isn't really enough. It's about getting people then to implement them, evaluate them, so we can then say, is this going to work in this population, this context, etc. And what we're actually saying to people is, we don't have necessarily the exact right thing right now, but what we have at the moment is the best that we have. Let's implement that, but we need you to evaluate it in a really robust way, and these are the skills and the tools that we need you to apply to be able to do that, to then build back to the evidence.
to come back to Amanda, so as kind of concrete example then, you know, been involved in the development of kind of mass media interventions to target gay men around HIV testing. And say, I don't know, maybe it was 7 years ago or something. So we did a lot of qualitative and quantitative depth work, but then the health board who initiated the intervention just commissioned an advertising social marketing company who came up with some really gimmicky posters. So, you know, then recently the same health board have funded us to do a systematic literature review, to use the behaviour change wheel, to work with designers from Glasgow School of Art about how to unpick what the components are. So in a very systemised but also imaginative and creative use, to actually be able to provide a commissioning brief which is theoretically informed in terms of things like the behaviour change wheel, but it's also informed by the expertise of design experts from the School of Art. And I feel confident that will be better than what would have been offered without. Of course, I hope we've got a really nicely designed intervention. We can get further funding to evaluate it properly and to make a very decent contribution through looking at routine data, looking at biological data collected in gay bars as well as online. We can use all of this to get some good evidence, but that's the icing on the cake. I do feel we've done a really good job just in terms of moving from some commissioned gimmicky thing that might have some visual appeal to something which is really targeting particular mechanisms of action and utilising particular behaviour change techniques, that we have a sense of what our ideal fidelity would be. And if it wasn't for systemised frameworks, I don't think I would be able to articulate quite what this intervention should be. So there's something about, you said it's, you know, it should be the evaluation. It should be, but just pragmatically, it's not going to be for a lot of us. And I think it's about knowing our added value of what have we brought to the table as health psychologists, and about what's good enough rather than what's ideal.
But you could have developed that 10 years ago from your experience and your research on your understanding the literature without saying it's informed by the behaviour change wheel. The saying it's informed by the behaviour change wheel might have helped you get the money because they like that, but you still could have done it because you knew from, you know, you've worked in gay men's sexual health forever. You could have just done that. He's got no hair. He's obviously not a spring chicken. He's been around, not as long as I've been around, but he's been around for a while. But you knew that stuff. Yeah, of course you did. You could have, 10 years ago, someone could have come to you and say, Paul Flowers, from your expertise, please develop us a fantastic intervention, and you would have done it. And you could have done a bit more interviews and all the rest of it, and you would have come up with a lovely intervention. Saying, it's this, informed by theory. We're all informed by theory all the time. Everything's informed by theory. But now we have to say we're informed by theory, and we go informed by theory bracket, and we put a reference in the box. But we're always being informed by theory. So 10 years ago, you would have done a fantastic job of what you were doing, but you wouldn't have said informed by theory, brackets, behaviour change wheel, bracket, reference, which got you the money. So that's the good bit. You got the money, but you could have done just as good a job.
I don't think I could have.
You don't?
No, so I think back, and it just reminds me, so, you know, one of the projects was an IPA project talking to gay men about their testing decisions, and then the intervention that I designed with a sexual health agency was kind of verbatim quotes which illuminated the complexity of decision making to enable people to make complex decisions. Whereas the current project, by using the behaviour change wheel, it's walked me through a process of being able to look at evidence of effectiveness, of looking and mapping across heterogeneous interventions, what have other people done. So there's something about the process of how the behaviour change wheel has led me through a systematic process, which, I mean, obviously I've learnt a lot in the last 20 years as well, but it's led me through to be able to think more conceptually, more theoretically, and in a way, I think this is why I'm a real fan, much more than something like the reasoned action approach, for example, or a lot of the kind of social cognition models did not help me engage with theory and think about the active contents of interventions which need to be matched to the mechanisms. So I know, it's not comparing like with like, but I do think it has given a lot of added value, but a lot of that has to do with my learning in 20 years as well, I would say.
Chris.
Hi, Chris Fiveshaw, University, sorry, but I'm speaking as a chair of an RFPB RAC committee, so NIHR, dishing out NIHR funding. What we've seen in recent years is people making bids for research for patient benefit trials where they're going to put in an intervention, which they claim has been informed by the behaviour change wheel. We've quite, in many cases, don't believe this, because what actually looks like is they were always going to do what they were going to do, because they've got a great long list of publications which suggest that's what they do. And they've, after the event, put we've designed this using the behaviour change wheel in early because they think that will press the right button with us. And actually, we've become quite cynical about that. So, bit of comfort for some people over there at an earlier point. But I think the behaviour change wheel doesn't actually tell you what to do. And people decide what they're going to do, and then they seem to do reverse engineer it and say, this was done because of the behaviour change wheel. And I'm not sure it's the way round in which we've been talking about it.
And the reason why they do that, because I've done that as well, to you, since you took over that committee, damn, I got that wrong, is because we've had other things rejected, or papers rejected from journals or from funding bodies which said, is this theory informed? Does this intervention use, for example, the behaviour change wheel? Or when you talk about behaviour change strategies, which behaviour change strategies reference are you using? And so we've had that back, and so then we thought, bloody hell, all right, we need to write that in to our applications, because that's the work. And so it's become a dynamic. So it's starting to kind of gain momentum that we're told we have to do it, so we do it, and it's actually not helpful.
Yeah. I mean, they're very, very different ways of using the behaviour change wheel. There's kind of retrospectively fudging it. There's doing it for pragmatic economic reasons, or there's doing it from the beginning and doing more than it says because you can improve on it. So I don't know, it seems wrong, there's no one way of using it, there's multiple ways
Thank you.
So I was thinking about what you just said, and particularly about what Anne said earlier about what patients need and clients need. And so there is, if you have this systemized collection of things, whether it's the behaviour change wheel or another sort of selection of solutions, whether you take those off the shelf and use them, or even if you decide beforehand and then choose which ones you have now used, it's not the values that we should really be passing on and sharing and disseminating. The values are more about focusing on why you're using them and having that basis of, okay, these are the people I'm working with, this is what they need and what they want, and how we want to work with them, rather than just plucking, okay, I'm just going to use this BCT because it's evidence-based and this is what everyone says is the good thing to use. So I think there's more than just those instructions that we should be, passing on.
I mean, if you've got the money, you'd take the off-the-shelf intervention and do a decent implementation science piece of work where you're looking very carefully at the key intervention users, deliverers, and key stakeholders, and working with them about local implementation. So, I think that's what you'd do. So it's not, you have a whole process, a whole other kind of research project where you'd work to make sure that it is actually acceptable and feasible within that particular target population. But sometimes that's not going to happen, and if you're dealing with a constrained budget, then that becomes too expensive.
Thank you. Max, just behind you
Jo
there.
Hart, University of Brighton. I just think about the mood in this room, and it's very, very different to Padua, where there was much more positive view around this whole behavior change, whatever you call it, wheel taxonomy. Basically, we are setting up a taxonomy, and I guess that's some indication of some maturing of the area of research we are in. And of course, every taxonomy can have umpteen problems, And as Chris rightly pointed out, also we are now gaming with it. And that's unfortunate, but yes, that's what happens. But there are issues which I found much more interesting. So what kind of, if we at least accept that scientists develop taxonomies, what should this taxonomy look like? And I think one of the key issues is that for all these taxonomies, we seem to have focused very much on the individual rather than on social processes, like in relationships between spouses or parents and children or whoever you want to take. There are other issues about contextualizing this in this. Should this be part of the taxonomy, or should we just see certain mechanisms or certain behavior change techniques work in one setting and not in another? So these are the more interesting things to me which might drive the science forward, rather than wondering whether some nurse might abuse our taxonomy. I mean, she's very welcome to do that, because I think this is a democratic process and not where we protect our sort of property, so to speak. So I actually take quite a strong view. We should share it, and we should maximize or aim for the best taxonomy possible. Or there may be multiple, I don't know. Anyway, I better shut up now.
Just to kind of echo your sentiment, so I absolutely agree. We need to be. I do. You know. I like systemized theories, but we also need, as health psychologists, to be agile with things like normalization process theory. We need to be able to think around community systems. We need to be able to understand our health psychology problems on multiple levels with multiple theories. So although I do think it's great to kind of mop up the variability with a systemized theory, more psychological or individually, I think that does beg of us to be able to imagine, well, how can we think in an understanding of the individual embedded in multiple social influences, but how should we be able to conceptualize and theorize or even have taxonomies that actually address these much wider systemic ways of thinking about how behaviour change is actually embedded. So I think I would agree completely there's a need for pluralistic theories.
Can I just make one very quick comment? So I'm interested in diabetes, and when you look at how diabetes patients operate, they actually almost at times, or those who live with somebody or have close relatives or other friends, what happens is not really that one person self-cares, it's almost that a family cares or so. So I think that particularly with chronic disease, processes are often not anymore really individual. And I think as this is a main target area for this behavior change taxonomy, I think there may be certain processes which are really fundamentally social rather than, one person acting and another responding.
I would say go even further than that. So say, if we think about intervention fidelity, quite often we'd think about how an interventionist delivers an intervention, but a lot of the active content can be within a familial context. So it's about those relational dynamics that boost what was offered to the individual. So, there are key issues about how we think about the other agents that are not necessarily specified within our interventions. So really.
So just to go back to the notion about taxonomy, if the taxonomy is individually driven or it's derived around the individual, and then you're looking at something that's worked, I was just thinking when you put those slides up yesterday of your media campaigns at work versus those that didn't, and then you code them according to an existing taxonomy, and that taxonomy doesn't have something like relationships or friendships or chatting or smiling or stuff in it, or the thing I said to you in the corridor, what I thought worked was yours was about kind of passivity or whatever, then you miss it, because that taxonomy has given you a way of thinking about it, and so you're coding it to an existing set of words. But actually, going back to Pippa's sitting there, but what worked for leg ulcer treatment was relationships. It was having relationships with people. Well, that's not there. Chatting to someone's not there, but they're important. And that's the problem with a pre-existing taxonomy, is it then you code it to that, and then you miss the interesting bits around the edges.
I think that interrupts fixed. At least that's my impression. That's how I think about it.
Okay, thank you.
I would say we had a really similar experience looking at using the behaviour change wheel with breastfeeding and motivational interviewing and peer support, that we found for understanding the technical components of the intervention, it was really, really useful, and thinking through what behaviour we were trying to change and what was driving that and what we could use. But the interpersonal relational aspects of the intervention just weren't really incorporated in the behaviour change wheel sufficiently at all.
And I would say, in terms of, say, the project that I presented on yesterday, then the behaviour change wheel does great things. It does things through a particular lens, but it's an awareness of what it doesn't do. So we had a narrative specialist look at these antimicrobial resistance interventions, particularly to kind of compensate for some of the weaknesses in the framework, to be able to think about the stories that are told within interventions. And I think, that's something that can't be, you can't do that within a taxonomy which says it's looking at things in a molecular kind of level, or again, thinking about visceral affect. How do we respond to public health messages? Then, that might get coded as kind of emotions, as but it's not actually telling us about some of the depth and some of the tools that are there that we could harness. So, I don't think that the systemised approaches can do everything, but they do a fair bit, and they do it very clearly, and that's a very good thing. But I would also really hate to think that it precluded us thinking about some of the other skills we have, some of the other ways we need to develop and conceptualise the social world and how it impacts upon people's behaviours.
But if we're trying to develop a taxonomy, and 1 year we say it's got 72 things, and then the next year it's got 105, and then one day we will say we've got all of them. Well, we won't ever have all of them. That's the problem, because they won't get eyebrow. Rachel's raising her eyebrows. That's really powerful. Eyebrow raising. We'll have eyebrow raising in there. That's one of the best. It's one of the best behaviour change strategy that we've got, is our eyebrows. It's fantastically successful. Oh my God, let's add that in. Let's add eyebrow raising in. Okay, then we've got 4,000 taxonomy, because we've got eyebrow raising and foot twitching and knee doing this, and so we either have everything, in which case it's unusable, or we have some of them, in which case it's not useful. So I suppose it's where you stop. It's never going to get everything, and if it could possibly get everything, it would have 4 million things and it would be unwieldy. So it's the kind of the why do we even need it question, really. It's good to have a language, but maybe eyebrow raising isn't eyebrow raising. Maybe it's called something else. It's surprise. Oh, I don't know. So it's just, where do you stop? That's all. I just think it's a venture. I'm just going to carry on for a minute. I remember the days, because I am feeling old at the moment, me and Di and Viv, we have decided we are the oldest people in the room, and Chris, how the hell does that happen? But anyway, I remember the days where they started to code the doctor-patient consultation. I don't know if anyone else, actually Tony, you're old as well. Do you remember that? So a guy called Philip Lay was obsessed with coding the consultation, and they said, let's code the doctor-patient consultation. And they had a taxonomy of what went on in the consultation, and it went on for years, and in the end you could see he just gave up, because it wasn't feasible to actually do it, and then they stopped, and then we all moved on. So I just think it's not doable.
I'm going to start drawing us to a close. I'm not sure we're going to resolve this. Any other comments from the audience of anything you would like to say additionally? Anything outstanding? Chris?
This is back to the issue of language, etc. One of the things I've noticed in this afternoon's chat is that we've switched between using taxonomy, model and theory as if they're all the same thing. And I think we need to be careful and use the word theory only when we're talking about a fully worked out set of propositions about how a process works. I mean, the behaviour change wheel is not a theory. It's a taxonomy kind of thing. And so I think that's something we could do for the discipline, is to try and be a little bit more disciplined in how we use the words.
Good, that's a good take-home message, thank you. Any final words? Oh, sorry, Viv.
Just to be slightly positive, the question does say, will it bury or elevate health psychology? I think one thing we have to recognise is that this has certainly put us up there in terms of recognition from other professional groups. in terms of the health psychology contribution to the discourse around health and health behaviours. So I don't personally particularly think it's a taxonomy is a great ways forward, but I think in terms of elevating health psychology, I have to grudgingly say that I think it has.
Okay, thank you. But grudgingly. It's good to have a grudging positive and cooler.
That's a good positive note to end on.
I'm just going to put the dampers on again, sorry. Because I totally accept what's just been said. But at the same time, if as a health psychologist I offer taxonomy to my dentists, for example, who love systemization, they would love for me to be able to say, do A and then B will happen. They would love me for that. But when I do that and it doesn't happen, as Jane said, there is no evidence that it works, then I think the danger we have is that health psychology will collapse back to where we were before the taxonomy came to save the day. So I have a lot of time for the taxonomy, but I also have a lot of time for what Jane is saying. I think unless it works, we've got to be very careful with where we offer these taxonomies to.
Thank you. Di, final point, and then any of your final points. Di?
I was just sort of thinking back to something Jane said earlier on, which was around the fact that, you know, we go through waves, things come and go, and it's what we're all talking about at the moment. But I think the clever people would be able to work out what we're going to be talking about in 10 years' time, and there would be, because it's going to evolve, and we might shift on to something else. So it goes back to that point. But we don't want to put all our eggs in one basket. We don't all jump on this, and that's the only thing that we do. But let's not throw it away either. But just recognise how broad we are as a discipline. And if you think about all the issues, all the patient groups that we're working with, the health is huge. We're never going to have one single thing that affects everything. It's about being pragmatic, using a bit of what, you know, seems appropriate at the time. So you can tell I've got no structure to anything I do. But it's just being pragmatic and just accepting things can be useful, but not being blinkered and only relying on things in a very structured way.
Thank you. Any final concluding points, or do you think we've aired all that we need? Paul?
I suppose just a discussion then about will we ever know the behaviour change wheel has worked or systemised theories work? I can't think, unless something deeply unimaginative, of research design that can ever tell us whether they worked. What we will know is whether the interventions that have used it as a tool for their development or implementation, we will know whether they will work. And I think that's where the truth lies. It's how they're tools. They're not, you know, it's how we use them, not them in and of themselves.
I think that, I suppose the really kind of top level thing is I think that everyone should do what they're passionate about and excited about. And that's got to be the bottom of why we do things, isn't it? It's because actually we enjoy it and we're interested in. If you find a patient group or your friend of a friend has a problem, or, you know, you go through life and you get interested in lots of different things, and we should be able to do all those different things that we want to do. And if this grabs you, good, go for it. You know, well done. You can have your lovely models. I don't like being told what to do, and I don't like having to do what someone else has just told me to do. So I'm going to not do that. I'm going to do my own thing. But we've still got to love it. And I suppose that's what I was thinking about this conference, is it would be such a shame if it became very narrow and everyone jumped into one thing and everyone did the same thing, because we shouldn't be doing that. We should just be doing what we're interested in, and it should be broad enough for us to be allowed to do that, really.
Thank you. I think the passion and excitement is a good point to end on.
That's what I was going to say.
Yeah. Thank you so much to all of you for your contributions. I think Mags Hustad has worked very hard on this, so I think she should be congratulated for a job well done. It's really got us thinking about stuff and talking about things. So a round of applause for Mags, please. And a round of applause for our keynotes, who we've worked very hard, as well as doing their keynotes, who've given us so much to think about. I think we shouldn't attempt to summarise this, but just to think about the issues that have been raised that I think are at the very heart of UK health psychology and where we're going, and we should continue to think about them. So a big round of applause for our keynotes. And thank you to all of you watching elsewhere in the UK or outside the UK. Hopefully you'll join us next year in Newcastle for more discussion and debate on a topic still to be decided. Thank you very much, everyone.